I'm Winfield Raynor. I'm a surgeon. I went to Dartmouth College, graduated summa cum laude, Phi Beta Kappa, with a degree in biology. It was at Dartmouth that I sort of determined that I wanted to be, one, a doctor, and two, a surgeon. I went to New York Medical College in New York City and Westchester County, graduated my MD degree, and then stayed at New York Medical College in my general surgery residency of 5 years. It included rotations to Memorial Sloan Kettering. When I graduated, I went into private practice of surgery. I think the biggest reason that I'm passionate about breast surgery is the fact that it has touched me very closely. When I was in practice the second year in the Meriden area, my mother's doctor called me and said, "Win, we've got a problem." And I said, "Oh." He said, "Mom had her mammogram yesterday." And I said, "Yes." And she flew to Florida today. And he said, "Yes, and it's abnormal." And he sent me the mammogram, and as soon as I put it up on the board, I knew that this was a cancer. My mother went through 25 years of dealing with cancer 3 times. Each time was successfully treated. And when she did pass away 2 years ago, she was free of disease. But during that time, I consider myself a survivor with her of that process. And I think that experience caused me to become very passionate about the treatment of breast cancer. And as a consequence of that, and indeed my mother-in-law's 2 breast cancers, my wife, my 2 girls, my sister, and my 3 nieces are all at somewhat higher risk for the development of breast cancer, and that brings it home. Breast cancer is unfortunately a common disease, but as a consequence of that, we have learned a lot about treating the disease, and we are constantly changing that treatment to the benefit of our patients. About 15 years ago, in the surgical community, an event called sentinel node biopsy began to take over for determining the spread of breast cancer to lymph nodes and the spread of melanotic cancers to lymph nodes. I became one of the first in the state to study this problem and to learn the technique, and brought it here to Manchester and set up a program to do it appropriately. I was also involved in the largest national study of the utility of sentinel node biopsy, and ended up submitting 49 of my cases to a study with 4,000 and something from the University of Louisville. As a consequence of that, I think all surgeons at Manchester ended up doing the procedure well and with the right technique and safely, and with monitoring to make sure that we were all doing it correctly. That's a small microcosm of what we can do with advances in breast surgery. I think another advancement that is occurring is that we are now doing less lymph node dissections or removal of lymph nodes, even if lymph nodes are positive. And that is because we are following the national data, which are showing that some women do not benefit from lymph node dissection because they're going to receive other treatments that will treat those lymph nodes. All of this is brought to the forefront in our educational conferences that we have here at ECHN. And all of our surgeons are involved in that. And we also learn from each other in that the surgical department learns from the medical oncology department, who learns from the radiation therapy department, and we all learn from the support services and the navigators. I think treatment of any disease, but cancers in particular, require a team approach. Surgeons, treating physicians, patients' families, and friends all have to have a good idea of what are the problems that we're facing, and what are our goals, and what are the ways we're going to reach those goals. So I think anytime we have a patient who has a diagnosis of cancer, it behooves us to spend the time to talk with those patients about those goals and have a good understanding about how to get there. That leads to a somewhat close medical relationship, more so than a simple removal of a skin cancer or that sort of thing. Out of that comes what I almost would call friendships with my patients. And I have to be careful, but we become a team together and we get to know each other. And it has led to many of my breast cancer survivors who are willing to become associates of new patients that I have and to help them get through their problems. And then it leads to kind of fun things when a patient might come to my office with her race for the cure number with a little thank you to me. And that makes me feel good at the end of the day. And I know it makes her feel good when she sees this every time she comes back to my office. This has been a developing partnership over time. The program for care of breast patients has really shot off in the past couple of years, but it has been developed over the past 15 years that I've been here. First with the sentinel node biopsy, which I mentioned earlier. More importantly, we now have an integrated program that includes physicians, radiotherapists, surgeons, and support staff, most importantly, the navigation program from both the Breast Collaborative and from the Cancer Center. I happen to be one of the two medical directors of the breast program and a medical director of the cancer program, and that allows me to help shape the program into a caring, feeling, active, and responsive program. And I think I found that ECHN and the directors of the breast program and the cancer program are willing to work with the physicians to make cancer care happen in this community.